Good evening, everyone, and welcome to our lecture tonight. I see there's quite a few people still logging in, so I'm going to start so long just with the intro, and then hopefully it picks up quickly. Thanks for choosing our webinar tonight again. I know that there's a lot of webinars or nice webinars on tonight, so thanks for joining ours. And those, I see there's a few names that joined us last night as well. You must like us. Welcome back. I'm Tanya Nell. I'm an oral hygienist and I've been working for Wright Milners for the last 12 years. Because we have a full house tonight, we have over 250 delegates that registered. I've brought up some backup or brought in a guest speaker, Dr. Casper Jonker, that will introduce Dr. Seedat tonight, and he's also going to help with the question and answer session. For those of you that don't know Dr. Casper Jonker, he works at Medusa University and he's training the future endodontists of South Africa. So for housekeeping tonight for the webinar, after the presentation, we'll have the question and answer session, and then feel free to load your questions in the question chat or chat with us on the chat side, and we'll answer them at the end. And then after the question and answer session, I'm going to run through a few promotions, especially on our patent irrigation solutions, and then just some new additions, some updates on the HiFlex EDM sequence. So don't run away. I can see who logs off and I will find you if you run away. A recording of the webinar will also be available on our Facebook page. So if you want to share with your friends or revert back to any information, you'll find the recording on our Facebook page. So bear with me tonight. I quickly want to ask you, what determines an endodontic success? It could be multiple factors, but the first thing we always think of or automatically think of is the file system. So 4 or 5 years ago, we had one main file brand in South Africa. And today, I think we have 10 or 11 reputable file brands available. And they all work and they're all in the practices and everyone has success, or a lot of people have success with their endodontic treatments. So if you look at our Wright Milners file system options, like Perfect Dental, which is our generic line, which is a cost-saving alternative, and that has the same tip, same taper, and similar metal to the original file system. Or if you look at our HiFlex is our flagship file system, and it can negotiate any curved canal. The sales are increasing year on year, and the customer feedback is remarkable. So there is no question in today's day and age about quality or efficiency of the files that's currently on the market. The best file system is what works for you. What works for you in your hands, and also fits into your cost per treatment per patient. It's factors like irrigation protocols that have a big effect on the outcome of your endodontic results. So I am pleased tonight to invite Dr. Seedat and Dr. Casper on stage to discuss more on irrigation. Hopefully they didn't run away and they'll join us.
Yeah.
Welcome.
Thank you. Thank you very much, Tanya, and it's a real honor for me to join the webinar tonight. And it's great for me to introduce my longtime friend, Dr. Hussein, my main speaker tonight. He has attained his BDS degree from the University of Witwatersrand in 1999, same year I qualified. He completed the postgraduate diploma in endodontics with cum laude in 2009. He did his MSc in endodontics in 2014, as well as the postgraduate diploma in aesthetic dentistry in 2016. He's presented on numerous occasions for congresses and meetings. He's published publications in international and in local journals. He's in private practice in Umhlanga Rocks in Durban, and he focuses mainly on endodontics. So these are a few facts I didn't know about Hussein. He's a child at heart, and he still gets excited with his kids' gadgets and his toys. He enjoys the simple things in life, and he likes spending time outdoors and indoors with his family. And he loves celebrations and hosting people. I hope you will invite me at some time, Hussein. And over the weekends, he's a pool boy. And you can offer those attending this webinar a discount for servicing their pools. That's good to know, Hussein. Thank you very much. So I'll leave it now to you. Hussein, are you there?
Hi, Casper.
Here we go. Hussein, are you there? Can you hear me?
Hi, Casper. Can you hear me?
Yes, I can hear you, Hussein.
Perfect. Sorry. I think I had a problem with the connection there. That's why you couldn't see me earlier. But I could hear you perfectly,
No problem.
and Tanya as well. Thank you so much for that wonderful introduction. Yes, Casper, it is true. I am a pool boy on the weekends, and Tanya, that introduction of yours, I think you said it perfectly. You almost gave the entire irrigation lecture there. So, you know, the thing is, and I'd also like to welcome all my friends from around the country. I went through the list of attendees. Some very good friends in Johannesburg, Cape Town, also a good friend of mine in the Cayman Islands. Welcome to all of you tonight for this evening. I'd like to begin with the webinar. Casper? Casper, can you hear me?
Here we go, Hussein.
Casper, can you hear me?
Yes, I can hear you.
Yeah, I'm good. All right. So I'm going to enable screen sharing now with the PowerPoint. So
Okay.
just let me know if everything is good.
Okay. Are you managing, Hussein? There we go. Something's happening.
Yeah. Okay.
There we go.
Am I
Something's
on?
happening. Good.
Am I on?
Yes, I can see your slides.
Okay. Okay, perfect. Thank you so much.
Good.
So, as once again, welcome to everybody for tonight's webinar. And as Tanya said so clearly, you know, there's lots of file systems on the market. And for a long time now, I think the emphasis on every endodontic lecture or endodontic workshop has been solely on the file system, giving us the false illusion that it's actually responsible for the success of our endodontic treatment. So I decided to do a little bit of research on irrigation, and I thought I'd put together a simple lecture or simple presentation or on irrigation and share with you my irrigation protocol. This is my 21st year in practice, and I think nothing describes my experience better than this graph, because at the beginning of my career, when I knew very little, I thought I knew it all because I had just come out of university. And as time progressed, I realized that there's just a little bit more to this than I thought. And then I reached a stage where I felt I'm never going to understand this. And just when I thought things are starting to make sense, I reached a stage where I realized that it's far more complicated than I thought. In 1953, Herbert Schilder came up with the line, the capacity of lesions of endodontic origin to heal is 100% minus X, where X may be any factor that we neglect during the endodontic procedure. And he developed the triad of endodontic success, which was shaping of canals, disinfection, and the seal. But I think now, many years or decades later, we reached a stage where I feel we have more the endodontic star of success. And the star of success, the points of the star for me are CBCT, microscope, heat-treated or controlled memory, night-eye wire, disinfection, and seal, both coronal and radicular seal. So today we're going to look at just one aspect of this, and that is the disinfection phase of the procedure. And so together with the CBCT and our microscope and our files, we're able to negotiate MB2s. I even was able to find a tooth in which we had 6 canals, so MB2, DB2, and a palatal 2. And I even found a central incisor with 3 canals. But the big question is, these white lines that we create here in these canals, are they actually white lines or are they white lies? And Raphael Michaels has said this very well in an article in 2008. Are these really white lines or white lies? I mean, this endo looks pretty decent, but it failed. And after retreatment, we had complete healing of this case. So the pathology will persist unless we reduce the bacteria within the root canal system to a subcritical threshold. So in this irrigation presentation, it's based on 5 questions that I asked myself. And I plan on spending a few minutes on each question, answering each question, and hopefully irrigation will make a little bit more sense to us. So number 1, what are the aims of irrigation? What are the irrigants that we use? Number 2, it seems like a simple question, but it's so important. I think one of the most important questions: what syringe and what needles do we use? Number 4, how do we activate or enhance our irrigants? And number 5, what is my irrigation protocol? So we'll start off with the first one, that is the aim of irrigation. Now, the root canal system presents to us 2 major challenges. One challenge is an anatomical challenge, and the other is a microbial challenge. More than 100 years ago, Hess showed us that the root canal system is far more complex than we can think. He used vulcanized rubber within these root canal systems, and he showed all sorts of lateral canals and complexities within the canal system. 100 years later, Marco Versiani showed this, the very same thing to us with his micro-CT studies, which he's so famous for. So what this tells us basically is that the instruments that we use within the root canal system are not able to touch all of the walls. In fact, as the complexity of the root canal system increases, the more number of surfaces remain untouched. And it is only our irrigants that will be able to clean up those areas. For example, in an isthmus area, when we use a rotary instrument within the root canal system, the action of the rotary instrument brings the debris up coronally. But if there is no wall on one side, then it is just packed into the isthmus area. So what does that mean to us? What that actually means to us is that our interface between, when we introduce a rotary instrument into a canal, all it does is it pushes this, the pulp tissue up against the side walls, and if we do not irrigate properly, our interface is going to be GP, sealer, and dentine mixed with a bit of pulp tissue, and that's a perfect recipe for disaster. Then we have the microanatomical challenge with our dentinal tubules and our peritubular dentine and collagen fibers, and these dentine tubules are the perfect environment for microbes to embed themselves into. So so it is not actually bacteria that is the enemy. Yes, it is, but it is more the biofilm that it creates for itself to protect itself. So these microbes are then, they begin by secreting an extracellular matrix, and as this builds up, it becomes very, very difficult to penetrate. So one of the main objectives of irrigation is to penetrate and disrupt this biofilm. So the aim of irrigation is to create a flow within the canal. And we want to create this flow all the way to the apex and back up coronally to bring the debris up. And it has to exert a chemical effect, a mechanical effect, and of course, we have to think about safety, because the last thing we want is a hypochlorite accident. So what irrigating solutions should we be using? And I think what we need to do is we ask ourselves first, what irrigation solution should we not use? And the number one irrigation solution that was used worldwide is actually saliva, because most endodontic procedures done by general practitioners worldwide are carried out without rubber dam. And the one good thing that this COVID has done for us is to introduce rubber dam into most practices. Most of my colleagues that I speak to now that were not using rubber dam are using rubber dam, and saliva is no longer an irrigant that they use. So the main irrigants that we're going to speak about are sodium hypochlorite, EDTA, and chlorhexidine. So sodium hypochlorite has been used in endodontics since the 1920s, and the main functions, it has three simple functions. One is to dissolve the organic tissue within the canals. The second, it has an antimicrobial function, and the third, it has a lubricant action for the file. And the reactions that it undergoes, there are three simultaneous reactions that occur when hypochlorite is introduced into the canal. The first one is a saponification reaction. So it forms a soap when it mixes, when it breaks down fatty acids into soap and water. So that those bubbles that we're seeing is actually a soap formation. The second is the proteolytic action. So it goes for the amino acids. It neutralizes the amino acids into salt and water, and the chlorine ions that mix with that water form hypochlorous acid, and the hypochlorous acid in turn breaks down more amino acids into chloramine and water, and this is known as the chloramination reaction. And fourthly, it is highly bactericidal because it has a pH greater than 11. The action of hypochlorite is dependent on three factors. One is the concentration, the volume, and the time. So the higher the concentration, the more effective the chemical is, and the greater volume we use, the more effective it is. So when we say that, what we mean is that it needs continuous replenishment. And of course, the longer the time we irrigate for, the more effect it has. This is a video just to show a comparison between 2% hypochlorite and 5.25% hypochlorite on nerve tissue. And this was something I found on Facebook. But just to show you how rapidly a 5.25% solution will cause tissue to dissolve compared to a 2% solution. And the 5.25 is almost dissolved, and the 2% is still taking its time, and it takes its time up to about 12 minutes, I think, in this video. What we have available to us commonly in South Africa is our Milton solution, which a lot of practitioners are using, which is a good antibacterial, but it doesn't do too much when it comes to dissolving nerve tissue. The other is JIC, which is excellent. It's a 3.5% concentration. And then there's the 5% sodium hypochlorite that's available from Milner's, from the Pack Endo brand. So, and I will show you exactly how I use it. I alternate between JIC and the 5% solution, and I'll show you exactly what my regimen is. So let's look at the effect on biofilm. So the biofilm, a 1% solution like Milton's will just disrupt the biofilm, but a 3 to 6% will eliminate the biofilm. And chlorhexidine in this study had absolutely no effect on the biofilm at all. So it does nothing for biofilm as opposed to sodium hypochlorite. The World Health Organization has recommended sodium hypochlorite at a concentration of 0.5% for spills of blood and body fluid, and as an antimicrobial for surfaces. So how far in to dentine does hypochlorite penetrate? And this study shows that it can travel up to 300 microns into dentine. But bacteria travel a little bit further. In this study, it was shown that bacteria can go 375 microns into dentine. So it's very important to activate our irrigants, and we will come to that shortly. Now, after we prepare our root canal system, we form a smear layer, and the smear layer is made up of two components. It has an organic component and an inorganic component. And the organic component is made up of pulp and bacteria, organisms, and the sodium hypochlorite can take care of the organic component quite comfortably. But what it can't do is take care of the inorganic component, that is the dentine debris that's smeared against the wall and into the dentinal tubules. And if that remains, then we are unable to get rid of the bacteria from the dentinal tubules, and it affects our seal. And for that, we use EDTA. So the EDTA is able to bind to dicationic and tricationic ions like Fe3 plus or iron and calcium. And by doing so, it removes the inorganic component within about a minute. And it is self-limiting. It's not going to exert its effect on the dentine forever. As soon as all these calcium ions are all are saturated within the amount of solution that's in the canal, then it becomes inactive. But the limitations of EDTA are also there, and the limitations, the big limitation of EDTA is that it deactivates sodium hypochlorite. So sodium hypochlorite then loses its antimicrobial and its pulp tissue dissolving abilities if it's mixed with EDTA. And also, there's a risk of damaging collagen fibrils if we irrigate with sodium hypochlorite after EDTA. So we have to be very cautious in this regard as well. So in the last 10 years or so, a new chelating agent called etidronate has come to the fore, and it's being researched. And one of the leaders in researching this is Dr. Prasanna Nilakanthan, who I had the privilege to meet in Dubai in February, and he's at the University of Hong Kong. And just to give you an idea of what etidronate is, it is used in Paget's disease, and it is a mild chelator. So it's a weak chelator compared to EDTA, which is a very strong chelator. Now, the difference here is that what makes it so special, and why I feel that this may take over our chelating action in the next few years, is that it doesn't erode dentine as much as EDTA does, and the special quality of it is that it doesn't affect sodium hypochlorite at all. So it doesn't affect the tissue dissolving properties nor the antimicrobial properties of sodium hypochlorite. And we have the advantage of removing the smear layer as the procedure progresses. So what Prasanna Nilakanthan did was he actually took over research from Matthias Zender and developed this product, Dual Rinse, and it's a capsule that's mixed with sodium hypochlorite at the beginning of your procedure. And you rinse with it throughout the procedure and remove your smear layer as you're going along during the procedure. So I think we just need to watch the space for that. I have made inquiries about it, and hopefully I'll get some to try soon. And the next is chlorhexidine, which at low concentrations is bacteriostatic, and at high concentrations, like 2%, is bactericidal. And it's able to eliminate all gram-positive, gram-negative bacteria and yeast, but it does nothing to a biofilm. Its main advantage is that it has a property called substantivity, and this is because it is able to bind to hydroxyapatite crystals. It can't dissolve tissue, it doesn't do much to the biofilm, and it has absolutely no effect on the smear layer. I think there is a place for chlorhexidine in the endodontic irrigation regimen, but it is not to be used during the procedure. I use it at the very end and only in certain cases, which I will describe later. And also a new product that's been launched is the 2-in-1 EDTA plus chlorhexidine. So this is also very helpful at the end of the procedure, especially in infected cases, to open up those tubules a little bit more and to introduce chlorhexidine deep into the dentinal tubules. And the good thing about introducing chlorhexidine in infected cases is the substantivity property, which will keep it active for weeks after it was placed within the canal. The one thing we cannot do with chlorhexidine is mix it with sodium hypochlorite, and that's because it forms a precipitate. So it's an orange-brown precipitate that forms that called parachloroalanine. And if you get this on your dentinal wall, it is very, very difficult to remove. And it is also toxic. So those are the basics on the irrigants. And we're going to cover a little bit now about the needle and the syringe that we should use. So what we carry out is positive pressure irrigation. And we say positive pressure because we apply a force on the barrel and the liquid inside is at a greater pressure than the liquid at the end of the needle, and that's the reason it is released. And we call this positive pressure irrigation. So the most ideal syringe to use is a 5 ml syringe, and it has to have a Luer lock. A Luer lock because we want to prevent accidental detachment and irrigation solution spilling all over the patient's face or clothes. The needles can be divided into either open-ended or closed-ended needles, and this is really important to identify. We have to know what needle to use in what scenario. For endodontics, at the very end, we have the multi-vented needles. That's from our Endovac system, but it's not commercially available for standard irrigation. So the ones that are more commercially available are these: the open-ended notched, the closed-ended, and the closed-ended double-side vented needle. So let's look at the jet, the jet that's emitted from these needles. So if we look at an open-ended needle, this study showed that the jet that's emitted is at 1 millimeter from the apex, it was fine. 2 millimeters from the apex, it was still able to reach the apex. 3 millimeters, it was battling a bit, but with the right amount of force, it was still able to reach the apex. And what this tells us is that if we are using an open-ended needle, we have to position it 2 to 3 millimeters from the apex. A closed-ended was actually the jet only traveled 0 or at the maximum 1 millimeter from the tip. So a closed-ended needle has to be positioned 1 millimeter from our working length. Now, when we say this, we have to understand to understand what size or what gauge of needle to use. We have to know our tapers and what size our instrument is. So I use a HyFlex EDM, and at the tip for the HyFlex 1 file, it is 25, and it has an 8% taper that switches to a 4% taper. So this is a regressive taper, and at the tip it is 25. So what that will actually correspond to is a 31 gauge needle, which has an external diameter of 0.26. So if I'm using a closed-ended needle, I can take it comfortably 1 millimeter before the apex, and I will introduce irrigation solution in that area. If I'm using the 2005 EDM at the tip, so 2005 means 25%. So then with each millimeter, it increases in diameter by 5 or 0.05. So it's a 20 at the tip, a 25 instrument 1 millimeter from the tip, and a 30 2 millimeters from the tip. So what that means is that to comfortably to irrigate this area, I'll be able to get a 31 gauge needle about 2 millimeters from the tip or from the working length. And I think then the ideal instrument to use, or ideal needle to use, would be an open-ended notched, because the jet would travel a bit further. But at the same time, now when I discuss with my colleagues about putting the needle so close to the tip, the biggest concern is a hypochlorite accident. And to avoid that, we have to stay within the confine of the canal. And to stay within the confine of the canal, we cannot practice endodontics without an electronic apex locator. So what the electronic apex locator will tell us is where the minor apical constriction or the minor apical diameter is. And what we have to realize is that we have two canals that we are dealing with in the root canal system. One is a dentinal canal, and the other is a cemental canal. So the cemental canal begins at the point where the cemento-dentinal junction starts. So it's around about the region of the minor apical diameter. So the instrument will give us our 0, 0 reading when it is at the minor apical foramen, and that will tell us where the dentinal canal ends, and this is the region up to which we should work. The cemental canal should only be entered with a recapitulation file, and that is either 8 or 10 file through that minor apical foramen. So now we're going to speak a little bit about irrigant activation, and there are 5 things that we're going to briefly cover. One is manual dynamic irrigation, sonic and ultrasonic. We're going to speak a little bit about photoactivated disinfection, laser disinfection, and negative pressure irrigation. So just very briefly, the first one is our manual dynamic irrigation, because now so far what we have been able to do is identify our canals, identify our dentinal canal, our cemental canal, clean out the dentinal canal, and irrigate only in that canal. But we need to introduce our irrigant into the lateral canals and all the complexities of the root canal system. So that's the main reason that we need to activate our irrigant. So this process, if you are doing nothing else as far as activation of your irrigant is concerned, manual dynamic irrigation, also known as cone pumping, I would say is the best thing you can do. It may not be as effective as the others, but it is very effective. It was developed by Pierre Marcoux in 1980, and what he recommended is to take a well-matched GP cone, trim it 1 millimeter before the apex, and 100 strokes for 1 minute, and use a 2 millimeter amplitude. And here you can actually see with the saponification reaction of the irrigation solution, and the irrigation solution being able to penetrate the isthmus area. So that's manual dynamic irrigation. The next is sonic activation, and a very popular device is the endoactivator. So an endoactivator, it generates a frequency or energy of up to 167 hertz. I went through a few of these over the last few years, but I've set my sights on the eddy activators, the eddy tips, which are polyamide tips, and this is powered by an air scaler, and this generates a power of up to 6,000 hertz. So it's far more effective than the endoactivator. Not as effective as ultrasonic, but the advantage of it is that you can put it into the curved part of the canal quite comfortably. So passive ultrasonic activation is actually my activation of choice for most of the canal, in which I feel safe using an ultrasonic, and it generates an energy of 25,000 to 40,000 hertz. And how it works is via three principles. One is acoustic streaming, cavitation, and heat generation. So the cavitation basically is the formation of the bubbles, and when the bubbles implode, they cause a negative pressure, and a shock wave is transmitted through the irrigant, and that generates an immense force. And of course, your acoustic or your sound streaming, and also it heats the irrigant within the canal. And a popular device to ultrasonically activate our irrigant is the NSK U file, which I've been using for some time, and then I found it might be in certain cases a little bit risky. So what I did was I used the U file, and I cut off I actually cut the file off at the shank, and I got my technician to weld 014 auto wire onto that. So that slots in, and I'm getting a lot of success with that. So far, no breakages. It comfortably goes into the canal, quite far down actually, and I can get good activation with the 014 auto wire. And just a case that I did recently with retreatment in which I used ultrasonic activation. So this patient had lost part of a buccal plate in that area, and I retreated, gave it a thorough irrigation, obturated using Neo MTA Plus, because I didn't want to discolor the tooth. And the difference between Neo MTA Plus and other MTAs is that it has tantalum dioxide as a radio pacifier, and this doesn't cause staining in anterior teeth. And 6 months later, we see just with good irrigation and good seal, the bone has grown back in that area. And initially, when I saw it, I was very doubtful. I actually thought that this patient had a fracture in that area and she was going to lose that tooth. And while on the topic of heating irrigants, I used to, for a long time, heat up my sodium hypochlorite prior to introducing it into the canals, and I stopped doing that. And one of the main reasons I stopped doing that is because the literature shows that if you heat up your sodium hypochlorite and introduce it into the root canal system, it evolves to intracanal temperature within seconds. So that actual temperature is not retained by it and doesn't have much effect. So you have to heat it in vivo. You have to heat it in the canal for it to have a good tissue dissolving efficacy. And also, whilst on the topic of heat, EDTA is not to be heated because it decreases the calcium binding capacity of it. As well as chlorhexidine. Chlorhexidine, the last thing we should do with chlorhexidine is heat it because it forms parachloroalanine. This study was actually answered a lot of questions for me as to the taper size to end on, because we've been taught to end on larger taper sizes, but nowadays we're moving into minimally invasive endodontics, and we're finishing canals with 25%. And this study, which was overseen by Professor Neelakantan as well, showed that you can finish with a 25% taper, provided you use ultrasonic activation in the canal. What it actually showed was that root canals that were prepared up to a size 40 were cleaner than the smallest, than size 20. But when ultrasonic activation was used in a 2005 preparation, it was as clean as the number 40. So I feel quite comfortable finishing on this taper with this in mind. And this is a very recent paper. It's about 2 months old, in which the endo activator was compared with passive ultrasonic activation, as well as the eddy. And what it found was that the passive ultrasonic activation and the eddy were far more effective than the endo activator, but it wasn't actually about that. What it actually tested was a new technique that was proposed by these authors called stepwise intraoperative activation. So at present, the technique that we are taught is to complete our procedure with irrigation and then activate at the end. And what these authors investigated was the cleanliness of the canals when it was activated in a stepwise fashion. So each third that they prepped of the canal, they activated the sodium hypochlorite irrigant, and at the end they assessed the cleanliness, and they found that the stepwise intraoperative activation was far more effective than just activating at the end of the procedure. And I found myself in the last few weeks trying to get used to this technique. Laser activation of sodium hypochlorite, it functions by cavitation and acoustic streaming, and the studies are unanimous. It is far more effective than ultrasonic activation, and I only had the privilege of using this once when I did an endo on a dentist who was using a diode laser. So he asked me to activate his irrigant with it. Photodynamic therapy. This is also something that I've been experimenting with lately. This is the Flashmax P7. How it works here is that light at a specific wavelength is combined with a photosensitizer, and then we have these reactive oxygen species that are produced, and these are rapidly biocidal. It's actually excellent to get rid of biofilms. So I've done a few cases with this, especially on very resistant cases that had previous retreatments failed, apicectomies that have failed. But it's a little bit early. So far, some good results. I'm just waiting a few months to get healing on these cases. So photodynamic therapy holds a lot of promise in endodontics. There's a lot of research coming out from Anil Kishan from Canada, and I think there's a definite place for this in endodontic treatment. Negative pressure irrigation, or our EndoVac system. Basically, this is a very safe technique for introducing an irrigation solution. We have a master delivery tip and either a macro or micro cannula, which sucks up the irrigant as it is introduced into the canal. So the irrigant is introduced in the coronal region. Our cannula is within the canal system, placed to working length or whichever point we desire, and it sucks in the irrigant, refreshes it constantly, and sucks it back up into the system. And I like particularly using these in open apex cases where there's a risk of extrusion through the apex. This was a case that had a previous apicectomy, and the apex was wide open. So I used the EndoVac quite comfortably and sealed with Neo MTA Plus in this scenario. And if we don't have the EndoVac system, we can still use a modified EndoVac system by using the Surgitip Endo. I do this quite often to clean the isthmus area. So the Surgitip Endo will fit comfortably into the canal. We introduce our irrigation needle into the adjacent canal, and it just sucks up all the irrigant into that isthmus area, giving us a nice clean. And another function of negative pressure irrigation is also something on the horizon with endodontics, and that is cryotherapy. So what Jorge Vera from Mexico and Philippe Sleiman have worked on is introducing cryotherapy into the endodontics. What that means essentially is that we introduce a very cold solution and run it through the root canal system, and that reduces post-operative pain dramatically. I've tried it with the Endovac, with modified Endovac, and the whole idea is to reduce the temperature of the external part of the roots to below 10 degrees Celsius to what it is. And all it requires is ice cold water, ice cold saline that you run through that system. And this article recommends its use for 4 to 5 minutes, but 4 to 5 minutes per canal can be a long time. So they actually in the process of testing what 1 minute per canal at the end of the procedure would do. And the article hasn't been published yet, but I watched an interview with Joge Vira, and he said that the results are promising so far in that interview. So I'm looking forward to that. So whenever I have a case where the patient was in intense pain and there's a lot of inflammation around the tooth, I use intracanal cryotherapy. So we're going to end off briefly with my irrigation protocol, and just to run you through it. It's for vital cases and just a small change for infected cases or retreatment cases. So when I start my irrigation procedure, I use 3.5% sodium hypochlorite or JIC. Once I'm past the initial 2/3 of the canal, I switch to the 5% sodium hypochlorite. And the reason for that is because comparative to this 5% sodium hypochlorite, JIC is relatively inexpensive. But I want to use the stronger concentration in the apical third where it counts the most. And after having done that, I would activate my irrigant with ultrasonic for 1 to 2 minutes in each canal. And in the curve part, use sonic activation, or if we don't have sonic activation, to use simple cone pumping in that area. Then I flush it all out with sterile water, introduce 17% EDTA for 1 minute, and then I actually cone pump, use manual dynamic activation with the EDTA, and thereafter sterile water, and then I go back to 3.5% sodium hypochlorite. And that helps me keep, it lets my 5% sodium hypochlorite go a longer way, and I feel with similar efficacy. And then I end off with sterile water. If it is an infected case, then I end off after the sterile water, and after I make sure I got all traces of irrigant out, I end off with chlorhexidine 2% or the new EDTA chlorhexidine 2-in-1 solution. And I'd like to end off by saying that your endo is only as good as your irrigation. Thank you very much for your attention this evening.
Thank you very much, Hussein. That was awesome, man. Yeah, it's I can just concur with you as well. That irrigation is probably the most important part of your endodontic treatment, especially with working with with anatomy a lot now. You can really see how complex it is if you see all these CBCT and micro CT images and experiencing it for yourself. It emphasizes the importance of irrigation, because it's impossible for some instruments to get into those difficult to reach areas and the apex, especially these deltas and things. So I've got a question, Hussein. Can we use citric acid instead of EDTA because it's a cheaper option?
You can, but it shows that it has a bit of a harsher effect on the dentine. So the studies, it's I've left it out of the presentation because it has a much harsher effect than the EDTA on the dentine. And the last thing, because now what the studies are moving towards now is studying the micro hardness of the dentine after we finish our irrigation protocol, because we don't want to end up with a root that's susceptible to fracture. And that's why I feel that the etidronic acid is going to show so much of promise. It's not yet available in this country, but it's available in Europe. It's available in India. So I think it's coming. I've already contacted some companies and I'm keen to try it out.
Yes, I agree with you. What good thing about citric acid is to remove calcium hydroxide from your root canal. That's excellent. But they also say in literature that
Okay.
if you use it for short bursts, citric acid is pretty good. It removes the smear layer pretty well, and it's not, if you use it carefully, then the susceptibility, root fractures it's not that great. So it is safe, but I mean, you have to be careful with it.
Okay. I found negative pressure irrigation quite effective in removing calcium hydroxide from the canals. So negative pressure, also agitation, it
Works
gets
well.
it out quite nicely. But are you speaking of the calcium hydroxide like in the paste form, the Vitapex?
Yes, the paste forms, yes. It's very interesting. If you go to the European countries, the guys and the specialists are not on calcium hydroxide because of the difficulty to remove it out of the root canals.
Yes, especially the Vitapex material.
Yes.
With iodoform.
Yes.
Yeah, I usually, just a little tip there. I usually use if I have Vitapex in a canal, I usually use ethanol, and I find it gives me a good result in removing it.
Okay. There's another question here, Hussein. What size GP cone do you use for manual cone pumping? I suspect that's probably the size that you finish off with your final file.
Whatever size you finish off, you just snip a millimeter off the end.
Okay. There's another question. In the pack endo system, the third syringe contains alcohol. At which point would you use this?
I usually use. I don't frequently use it during the procedure. I usually use it at the end to clean up all my sealer from the access cavity before I do bonding.
Yeah, because it does dry out the tooth part. Huh?
Yeah, that is. Or if I have used chlorhexidine and for some reason I feel I need to go back with sodium hypochlorite at some stage, then I will use ethanol in the canal. Then I will use it because I want to be very sure that all my sodium hypochlorite is gone from the canal. Because I've had cases where I cause PCA or parachloroalanine to form in. And I think if you're not using a microscope, it won't affect you so much because you don't see the damage that you're doing in the canal.
Yes.
But when you actually see that stuff, you don't want to make that mistake again.
Yes, I mean, talking about microscopes and magnification, it's difficult. It's like a new world when you're using magnification to do endodontics. You discover things that you never knew there was.
Of course.
Yeah. Here's another question, Hussein. What's your thought on irrigation the canals with 99% ethyl or alcohol after using sodium hypochlorite to help remove the crystals or the salts that might form?
I suppose it could help if this would happen if you mix your sodium hypochlorite with EDTA, I assume. That's when you would actually get that type of reaction. If you are careful and don't cause that reaction to occur, you shouldn't have those crystals forming. But yes, I feel that it will help to remove that.
And I suppose when you're using I see that in your protocol you're using sterile water a lot in between your irrigation solutions.
Yes.
So I think that's very important as well to prevent all these effects.
Yeah.
Perfect. Okay.
Tanya, I don't have any more questions.
Yes, perfect. You're getting lots of compliments on the chat side.
Okay,
people
good.
Are very
here's
happy.
another question. Can I just take this question quickly?
Yes, 100%.
Can I take this question?
Yeah.
Is there still time, Tanya?
Yes, perfect.
Okay, so it says here, where's this one? Okay, Milner's Cell and EDTA cream, effective for lubricating canals during shaping. Can this replace the 17% EDTA?
No, it's not as effective.
You need the solution.
It's not as effective. You need the solution to remove the smear layer. It's good for lubrication. It does cause a little bit of softening of the dentine, but I try to use my solutions as lubricants. I used to use it a lot. I still do. I still do use it because I never want to put a dry instrument into a canal. But remember that EDTA is going to interact with sodium hypochlorite and make it ineffective. So, it's a balancing act.
Yeah, and I think that with using creams is important for scouting initially as well, huh? Otherwise, you get that
Yes,
slash. So I
yeah.
never use sodium hypochlorite for initial scouting. I think it's vital to use the cream in the initial stages of your preparation, your glide path. But that's just my opinion.
Dr.
Oh,
Jonker,
that's a
you
good
can
opinion.
take the
Yes.
last two. You can take the
Last
last
two
two questions.
Okay. How do you irrigate 1 millimeter from the apex on a severe curved canal? I think this can come probably back to the editor, but what's your opinion, Hussein?
Actually, on a curved canal, a 31 gauge needle will take you quite comfortably close to the apex. They're quite flexible. We just got to be careful not to wedge the tip of the irrigating needle into the canal. So just keep it moving, keep it vertical, keep it moving vertically. Never allow it to bind. If it binds, then just carefully wiggle it out and not forcefully, because we don't want to break the tip into in the canal as well. So
yes, and
yes, you can.
I agree with you.
But what you were saying is actually correct. If it cannot go 1 millimeter or 2 millimeters, as you must remember, there's a study that shows that ultrasonics will exert its effect 3 millimeters beyond the tip. So if you can get an ultrasonic instrument, or I assume because eddy gives us very similar action to ultrasonics, if you can get that within 3 millimeters of the apex, it should move your irrigating solution into that area, hopefully.
Yes, and if I can just mention as well, working with undergrad students a lot, the one thing that I take extra attention is to watch them when they irrigate, because they have a tendency to wedge the needle. So I just want to, concur on that one as well. The positive pressure is your biggest enemy. You can do whatever you want with the needle as long as it keeps on moving and you are creating negative pressure. Once you get positive pressure, it takes a minute amount of sodium to cause an accident. And it's something that's quite scary when you experience it the first time. It's quite a panicky situation. So that's the most important thing. Just keep it moving. Don't wedge it.
Sure.
Okay. This is the last question. What's your opinion on using hydrochloric acid as an irrigant?
Hydrochloric acid.
Yes. Yep.
Well, hydrochloric acid, there's no mention of it. You mean hydrochloric or hypochlorous acid?
No, it says hydrochloric acid.
Is it hydrochloric
Yep.
acid? I haven't come across it in the literature.
No, me either, I must say, because I think that the protocol that you've explained is pretty straightforward, and I think that should be the most effective thing to use as well. I think if you stick by that, you should have a pretty clean canal.
There were studies on hydrogen peroxide,
Yes.
using hydrogen peroxide in the canals, but
Yes.
it didn't show, it didn't perform as well as sodium hypochlorite. And there was a theory that if you mixed hydrogen peroxide with sodium hypochlorite, that it would be more effective. But the studies showed that it just caused a nice fizz. So it looked like it was doing something, but it didn't.
But
really
it's not really
do
doing
much.
anything.
No, it's not as effective. Hypochlorite is the gold standard of irrigants.
Agreed.
There's no point in trying anything else.
Perfect. Thank you very, very much, Dr. Seedat. Thank you, Dr. Casper. I'm quickly going to share the promotions tonight and just put on the HighFlex sequence and just discuss quickly while I've got you two that use HighFlex to help me and assist me. I quickly want to share my screen. Okay, so the HighFlex system, we used to have, still the orifice opener, and then you would open the canal up to a loose 10 K file, size 10. And then we used to have a 1005 glide path file. But the tip of the 1005 glide path file was very fragile. So the new glide path file that's eventually going to replace the 1503 glide path file, 1005 glide path file is the 1503 glide path file. Any comments on that, Dr. Casper or Dr. Seedat?
Tanya, I think the problem with the 1005, in my opinion, is that the taper was too large. So it had a 5% taper, So as it progressed coronally, it bound, and that was the reason that there were separations. So they designed the 1503 file, and this is an amazing glide path file. This file I cannot do without, and I battled these last few weeks when Milner's was low on stock. So I'm glad that stock's back in the country. But what they did was they created the max curve sequence. So the max curve sequence is to have if you got a severe curvature, it's a super loose number 10, followed by a 1503 glide path file used at 300 RPM and a torque 1.8, and then you use your 1005. So what they did actually was they created a glide path file for the glide path file, which I don't really subscribe to. I go straight from the 1503 either to the 2005 or to the final 25 file. But I find myself using the 2005 most often, even if the canal is not severely curved, just to be cautious.
Yes,
because you can get numerous uses.
We've also seen a huge increase in sales there with the 2005, and you can finish on it. And like you mentioned, it's got a 5% taper. So if you're using it with activation of your irrigation, you get efficient cleaning. And you can finish.
I wanted to say as well, I absolutely love that 1503. At university, I have the privilege of working with quite a few systems, and I mix and match my systems. So as the cases come. But I don't particularly like the 1502 hand file because I think it's rigid and it ledges very quickly. So when you have the 1002K file and you prepare it nicely, this 1503 is a nice transition for me just to go to the 2005 as well. It just does something, I don't know, it's a personal preference. So I've got no problems with the 1005 as well, but I prefer the 1503 in my sequences than the 2005. And then sometimes you can judge your treatment as well in some of the cases. If you struggle to get a glide path and a reproducible glide path, I will very often finish with the 2005 rather than to push it to go to the 2508 or the 25-1, the one file. I don't know, Hussein, if you do that, I'll take my chances and then focus on my irrigation rather than to risk a ledge or a fracture at the bottom.
No, for sure. If it's severely curved, the 2005 is more than adequate. And what's nice about the GP, or if the canal is very narrow, there's no point in enlarging it further. But what I really like is the 2005 GP fits absolutely perfectly to Apex. It's a very, very comfortable fit. When it came to the 25-1 file, initially we had a problem with the GP from Colteen because there was a misfit in the original GP, and so at present we are recommending using a 25-6% GP to obturate with when you finish with the 25 file. If I can just comment on the larger files, the 4004 especially, I've been using that a lot, especially on our palatal canals of upper molars or distal canals of lower molars, and I found that the transition between a 25-1 file and the 4004 is actually very small. You know, it looks like a big jump when you look at it. Yep. Look at it in right. It's actually very small because the 25 file. You must remember the first 5 millimeters is a 8% taper, so it moves from 25 to 33. To 41 to 49, so to go from that to a 44%, because the taper is much smaller on the number 40 file, so the transition is really small. So in large canals, it's very, very safe use. And originally, when HighFlex was launched, it was launched and it was said that it's 700% times stronger than other conventional rotary instruments, and I was trying to figure out where that 700% came in. So how it actually came in was from a cyclic fatigue study, and in the cyclic fatigue study, it was the 4004 that was 700% times stronger than the conventional. So that is a really, really strong file, and also the GP cones fit perfectly. So I think it's a great file. Also, another thing to remember. When using the Endovac system, the micro cannula, you'll only really be able to comfortably get it to apex if you finish on a 35 instrument.
Yes.
So
that's what literature says. Yeah.
So because the external diameter of the micro cannula is a 32. So when you finish on a 40 or 4, you can use the Endovac micro cannula far more comfortably in the canal.
Yes, and then just the benefit for me, on controlled memory, because it's just my opinion, but I feel that doesn't matter what system you use. And like I said, I use a lot of systems because I have a privilege of teaching a lot of systems, but controlled memory must be somewhere in your instrumentation. If you've got severely curved, especially with ledges, and you can get this controlled memory file just past that ledge and then activate it, it eats up a ledge like nothing. It just works in my hand. So I like that controlled memory effect as well. And because this file is quite rough, it's it just takes it away quickly. I just like it.
Yeah, one of the
for
things
sure.
I'll never forget that Antonis also said is, for a straight canal, use whatever you want. But for a curved canal, use controlled memory.
I think for me, the main thing is the confidence that I have when it comes to stepping up to larger sizes, like a 25, severely curved canal. I don't have a problem using it. The other advantage is the reuse of it, where you can sterilize it and it reverts to its original form. But I avoid using it more than three cases. 3 cases and I'm done. Then I keep it for straighter canals after that. So I make every time I use the instrument, I make a little notch on the handle with my burr. So I know how many times I've used an instrument.
Thank you for your input there. Then I just want to show everyone a video of the Pack Endo irrigation range. If you haven't used it before, it's got a very nice lure lock system at the top. So when you get your bottle, you get an extra lure lock insert, which you insert, and then your 5cc or 3cc or 1cc syringes fit into the lure lock cap, and you can retract this solution. So it's very sterile, well, not sterile, but it's clean, it's neat, and it prevents cross-contamination. So that's a very nice feature of the system. Someone's drag racing tonight.
Okay, that's outside
It's not
my
on
house.
my side, I promise you.
I hope they win. Yeah, so it just fits in. The assistants love it. No mess, no fuss, no jig on the clothes. And they literally just dispense their liquid into the syringes. Okay, so the promotions, this will carry on to the 31st of July, but we've got the Pack-10 2-in-1, and then also your chlorhexidine, your sodium hypochlorite, and your EDTA on promotion. Then your HighFlex files, it's any packs of HighFlex files. Buy 2, get 2 packs of K files at no charge. And if you buy 4 packs of HighFlex files, you're going to get a 120 ml 2-in-1 EDTA chlorhexidine solution mix, the new one. This bundle deal is quite nice and cost effective. So it's EDTA chlorhexidine 2-in-1. Where the EDTA, plain EDTA is, you can either choose there whether you want EDTA, sodium hypochlorite, or your chlorhexidine plain. You're going to get another small 2-in-1, your 5cc syringes, your EDTA cream, the question from before, and then your OptiProbe needles, which is a 30 gauge, the purple, for 3,618. There's your Endovac starter kit. And then the Surgitip Endo. Surgitip Endo on our side is very, very popular. A lot of guys are using it. Pack of 20, 697 Rand. And then the Venta handle. I just want to show you, it is on promotion. The handle is nice for microfile. Just want to show you this quick video on it, just to explain.
Can I just add something on the endo handle?
Perfect.
The endo handle, actually, the video will show you that it's recommended to form a glide path. But I don't actually do that. I use it to get into hard to reach areas where I can't twist my hand. And I had a case that I had videoed that I wanted to show in tonight's presentation, but it actually slipped my mind. But in areas where I really cannot get the right angle to introduce the instrument in, this endo handle helps me out. And I liken it to there's something I forgot to add, Casper, in my CV, is that I enjoy playing snooker a lot. So when
I didn't know that.
So when you play snooker, there are some shots you cannot reach, and you need an extension. So for me, it's the same as having that type of extension just to reach a certain area in the canal. But hopefully in future presentation.
I'm horrible with snooker, I can play snooker, but it's horrible. But yeah, I can. The other thing I just wanted to say about this endo handle as well, it's, when you're using magnification, especially the microscope, your fingers are always in the way.
Yeah.
And this thing is very handy.
Exactly.
In the initial phases, it's, just to get that out of your way as well.
So what I do with the endo handle is when I get my instrument, the tip of my instrument into the canal, I introduce it in, I leave it in place, I hold it with my left hand and I unscrew it. And I unscrew it and I get it off the file. And then after that, I give it more tactile sense with my fingers. That's the technique that I use with the endo handle.
A question that we get asked often is, can I use my normal K-files? Now, there is a video on the internet where they've taken a bird beak plier, ortho plier, and they've bent the normal K-file. The only problem is you can use it, it fits. You don't get the length. And the length is what you want for the difficult to reach area. So you can, but it's just a length problem. You also get this in C+ file where it's more aggressive. You get it in the H files and you get it in the K files. Then on the NSK side, Endomates on promotion, your Apex locator, if you don't have one, there's one on promotion for you. And then if you guys are interested in the eddy tip, David Dubell sells the eddy tip, but we sell an air scaler because you have to use it on the air scaler because it needs to go into a female connection. So if you're looking at the air scaler there at 4,999 on promotion. Then we've also got the U-files. There's 2 U-file kits. There's E11 and E12, and it's just a degree that's different. Dr. Seedat, I think you use E12, no?
I use E12. That's my preference.
Yes, and that's a 95-degree angle. Okay, that's my story on the promotions. Any questions on the promotions?
Tanya, I don't see any other questions on my side except that, yep.
Okay, 100%. Thank you very much, everyone. Thank you for your time. I hope you enjoyed the lecture. Thank you, Dr. Seedat. Always a pleasure listening.
Thank you.
Always learning something. Thank you, Casper. Thank you for helping us out. It was great to have you with us tonight. Thanks a lot.
Thank you very much.
Good night,
Thank you,
everyone.
Hussein.
Thank you,
Tanya.
Bye-bye. Thanks a lot. Bye-bye, guys. Bye.
Thank you.